Ladies and gentlemen, we hope that you enjoyed our opening keynote presentation by Mike Hall. Now, please welcome to the stage Dr. Ramya Sandaraman, who will be moderating the panel discussion around research and evaluation of suicide prevention strategies.
Good morning, everyone. Thank you all for being here. We have today a very esteemed panel of 4 panelists, and the panel is going to be talking about collaboration, not only across the federal government, but also with America's Warrior Partnerships and other non-governmental organizations. So really looking forward to all that the panelists have to offer. I'll give a quick introduction, starting with Dr. Matt Miller, who leads suicide prevention for the Department of Veterans Administration. Dr. Liz Clark leads suicide prevention for the Department of Defense. Captain Chris Jones leads the Injury Prevention Control Center for the Centers for Disease Control and Prevention. And of course, our Jim Lorraine, who leads America's Warrior Partnership, in case you haven't caught on yet. So let me start with just some broad questions for the panel, and thank you all for being here. The first question we have really goes to Captain Jones, Dr. Clark, and Dr. Miller. What is the latest data saying about suicide rates among our service members, veterans, and nations as a whole? So we'll start with you, Captain Jones.
Sure, and I'll take it from the broader national perspective in the U.S. Last week, CDC released a report based on provisional data for 2021 with the latest suicide numbers. And what we found is that although there were declines in suicide numbers and rates both in 2019 and 2020, numbers and rates went up about 4% in 2021. Based on the latest provisional data, I don't think when those data become final it's going to shift very much. So I think we feel pretty confident that we do see an increase in suicide. And for the analyses that have been put out so far, we saw increases both among males and females, and among males in particular, younger age groups 15 to 44 saw significant increases, and then the 65 to 74-year-old group as well. So I think it, certainly is discouraging in the sense that we had seen 2 years of declines, but I think we had been previewing that given all that has happened in the context of COVID and what we know from prior large-scale natural disasters or large-scale disruptions to society, that some of the consequences like suicide tend to be delayed from more of the infectious disease consequences, and that we believe that we might see an increase. And I think more than anything, it just underscores the importance of the work that you all are doing and that we're doing together to address the constellation of risks that contribute to suicide.
Thank you. Dr. Miller, would you like to go?
Oh, sure. Do you want to go next, Liz? Or okay. All right, so I'll cover it from the veteran perspective. As many of you know, we released a couple weeks ago our annual report, 2022, and that's based on 2020 data. We report across and try to organize it throughout the report by count, by measures of central tendency like average, and then by rate. Just a note real quickly about one of those 3, and that's average. From a statistical perspective, I'm not a fan of the average per day and reporting on that. The primary reason why is that it doesn't allow for a valid comparison from year to year, because really what you're looking at is you're looking at the count on top, the numerator, and the denominator is the number of days in a calendar year. Rates are the way to go from a statistical perspective in terms of making accurate comparisons, because instead of comparing it to the days in the calendar, it compares it to the total population for that year. So much better year-to-year comparison. Nonetheless, that seems to be, and I think you all have experienced this, that seems to be the number that everyone hangs on to. You know, you'll hear 22, you'll hear 20, you'll hear 17. This year it's 16.8. So we'll continue to report on that accurately, but just I'd appreciate if you kept that in mind. So from a count perspective, 2020 data indicated the lowest overall count since 2006 for veteran suicides. So if you plot and you look at where we were in 20, and then you draw a line in your imagination over to the left, you'll hit 2006, the last time it was there. But it's still over 6,000, and we firmly stand on the perspective that anything greater than zero is not what we want. When you convert that into rate and start taking a look at rate, and that's important in the veteran population because the veteran population is going down. So any changes in the count on top has to be in relationship to the declining population. As a matter of fact, then, the changes on the top have to exceed the changes on the bottom for there to be any difference. So what we found is if you compare 2019 to 2018, there's about a 6% decrease in rate for veteran suicide. And then if you take a look at 2020, there was another about 4.5% decrease. So taken together, since 2018, we've had a 10% decrease in veteran suicide rate. The next question I think is really practical is, so what does that mean? Is that meaningful? Well, there's different ways to answer that or address it, better stated. But if you take a look at 2001 to 2018 and veteran data, we were increasing on average every year by at least 2%. So every year we were talking about hundreds more veterans who are dying by suicide. There were a couple years where we went down a little bit, but overall it was 2% average. 18, we hit a peak, and it was at its highest in recorded time. So then for us to make a 10% decrease in 2 years, after 18 years of +2, +2, +2, that's meaningful. For at least from a statistical perspective, it's statistically significant. Now, from a practical perspective, you're talking about 650 lives. And that's really what I care more about. You're talking about 650 less lives lost to suicide across that time period. And that's what we want to continue to focus on and continue to address. That then gets into our strategic plan, which is heavily ensconced in a public health model and in close partnership with the individuals here sharing the stage with me, which then, maybe it's your turn, Liz.
Thanks so much. And very similar to Dr. Miller and Captain Jones, we also release an annual report with our counts and rates. We are getting ready to release our calendar year 21 annual report at the end of the month. So while they have talked about 2020 data, our last year's was published in September. Very similar type of data. It's a gradual increase over the past decade. Every life is one too many that's been lost. We do also publish on our website a quarterly suicide report that just publishes the counts. And that helps us with that preliminary data. What does our data look like? But truly then at the end of the year publishing then the actual rate, as Dr. Miller talked about, how important that is because the military population then changes and is fluid over the years. We also, within our report, do distinguish from the active component, the reserve, and the National Guard, understandably because of the differences that they have within those populations and the resources and programs available for them. We also publish in our report military family member data. And now that data is 1 year prior based on CDC information. So that will also be released for 2020 within our calendar year 21. This will be the first year that the department is releasing both as you all might be familiar with, the DODSR, the DoD Suicide Event Report, will also be coupled with what used to be called the Annual Suicide Report. So there will be one report from the Department of Defense that includes all of the suicide data and rebranded as the DoD suicide, our annual report for suicide in the military. So we're really excited about having that published at the same time. But again, with these gentlemen, every single thing that we're doing right now is really looking at to help every service member and family member so they aren't experiencing the loss of a suicide. I'm really excited today to be able to talk about some of our programs in collaboration with these two.
Thank you. Next question is for Jim. Jim, can you talk about the research and evaluation efforts that AWP is engaged in and any trends you're finding?
Sure. Thanks, Ramya. So America's Warrior Partnership about 5 years ago started to look at veteran suicide, former service member suicide, sorry. And what we looked at was to go back even further. When I was working on the Joint Staff, I used to work with General Corelli, who was the Vice Chief of Staff at the Army at the time, and really started an initiative where he wanted a deep dive into every active duty suicide that happened. And from that experience, flash ahead, we're at America's Warrior Partnership. We have a large amount of data. The chairman of my board said, could we use that data to identify trends or characteristics that might affect veteran suicide and how we would build prevention programs at the community. And so what we did was, at the time, as an example, we had Veteran One Stop Center of Western New York in Buffalo, and we had Tierney Center for Veteran Services in Orange County, California. And we were saying, okay, the veteran, because of the demographics, the characteristic of the veteran in Buffalo who's going to take their life looks very different than Orange County, California. A lot of other resources, different demographics of people, et cetera. So using what we had done, we did a ton of research to figure out, had anyone done community-based specific veteran suicide studies with the goal, the entire goal of Operation Deep Dive is to build prevention strategies that are aligned with the community, the demographics, the community resources that are available, the geography, et cetera. And so we got into Operation Deep Dive. We were fortunate as we moved through it is that we learned that there's some states that would provide us with all of the deaths of everyone who died in the state. Names and social security numbers, dates of birth, gender. Those data fields, in addition to like an electronic death record, are what we were able to share with the Department of Defense through a great partnership that we have and through our MOA. So what we do is send everyone who died in the state to the Department of Defense. They would come back and say, this is everyone who served in the military, and 135 fields of military history. It is amazing and almost staggering on the amount of deaths. So we had their military history and their death. And so from that Operation Deep Dive, we could go down and look to the zip code level, to the county level, depending on how large the zip code was. We never went below 20. We would always consolidate a bunch of zip codes to get the number high enough. But we started to look at community-based, like what does the panhandle of Florida look like as compared to Jacksonville, Florida, as compared to Tampa, as compared to Miami. And what we found was that the veterans who were taking their lives were different in those states, in those communities. And so it drove a different strategy. The other thing we found was states were different. So Massachusetts, as an example, when you look at Massachusetts, their number one cause of death for suicide, categorized as suicide, is overdose. Their lowest one of their lowest mechanisms of death was firearm. When you look at Montana, it was different. It was firearms were the highest, overdose was the lowest, as an example. The strategies had to be different. You couldn't take the strategy you used in Massachusetts and apply it to Montana and vice versa. You couldn't take the strategy you were using in Miami and apply it to the Panhandle. Different population, different set of resources, different geography. A lot of factors went into it. So when we put this all together from these 8 states, we started to step back and say, all right, so to what Matt said, I think it's the so what. I have the numbers, big deal. You have the numbers. So what? How can we develop prevention strategies, not count the numbers? I agree. The 17 the day count, it's easy for people to understand, but mathematically it's not. You have to use rates per 100,000, because then I can compare males, females, races. I can compare service types, Marines, Navy, Air Force, Coast Guard, etc. There's much more to be done, but I don't want to spend the time talking about the numbers, because it's not about the numbers. The numbers are make you realize where you're going, but really it's about the prevention, and it's about working together. You heard me say at the beginning of the thing, together we can do better. And I'm just going to say, together we can do better. And I know you all feel the same way, that we're all focused on improving the quality of life and reducing veteran suicide. But Operation Deep Dive for us was a way that we could equip our communities with a suicide prevention strategy that had measurable impact and outcomes. So, thanks.
Thank you, Jim. The next question is for you, Dr. Miller. Can you talk about how the VA collaborates with the Department of Defense and other federal agencies and community-based agencies on suicide prevention work?
Sure. I think there's multiple ways. And first, with this question, I would be remiss if I didn't thank Chris and Liz for their graciousness in collaboration, because they have to work with me, and that is not easy or fun. So I appreciate the collaboration. We have a lot of different mechanisms and means for collaboration. One that has emerged within the last 2 years has been the White House strategy for eliminating veteran and service member suicide. And that led to, that's coordinated under the Domestic Policy Council. And then many of you know Terry Tennelian from her RAND days and otherwise. She's heading up the DPC suicide prevention efforts for the White House. But there's 5 strategies or targets outlined within the White House plan, and then each of us are working on those 5 strategies and appropriate affiliated subcommittees. I think as a result of that, what you're going to see over the next year or two, I think you're going to see significantly more front stage activity and materials with regard to lethal means safety, in particular firearm-related lethal means safety. Firearms and suicide 70% of the time for veterans. And, Jim was talking about Massachusetts, and it's true. And you take a look at the state laws with firearms, and there's studies that are done on that. But yet, in Massachusetts, for veterans, firearms, even in that context, remains number 1 in terms of lethal means. So they may be closer to 50%, where Montana is closer to 76%. So firearm lethal means safety. I think you're going to see a lot about that, and you're going to see a lot from us with our Keep It Secure campaign moving forward. Chris is doing a lot of work on data and surveillance. We sit here and we talk about 2020 data, 2019 data, and I know you're having the same response that I've always had, which is Really? That's a while ago. What about something a little more immediate? So smart people like Chris and subcommittees are taking a look at how can we validly develop more rapid surveillance methods. And then, of course, Liz and I are working really closely together for HANA-NAC Section 101 implementation. That's transitioning service members, and HANA-NAC Section 102 implementation, which is the deep dive person by person into all transitioning member suicides that occur within the first 12 months of transition with an ensuing report. So that was off the top of my head what we have.
Great, thank you. The next question is for Captain Jones. Captain Jones, can you talk about upstream suicide prevention efforts and evidence for those?
Sure. And I think, much of how we think about suicide and sort of a constellation of risk has already been talked about. I think everybody has talked about it, and that's part of, what we view as a comprehensive public health approach to recognize that there are acute factors that play out in someone's life or in their relationship, as well as longer-term factors that contribute to suicide risk. And our approach and under our comprehensive suicide prevention program, which I think undergirds DOD and VA's work as well, and certainly much of the work that you heard about from Jim, and thinking about there's variation across communities and what are drivers and contributors to risk. And our sort of foundational principle is that we need to be paying attention to those risk factors and getting as upstream as we possibly can. So several years ago, we released what we call a technical package. And I know it's a terrible, terrible name, but it's such a good government name because no one knows what it is. But it basically is a roadmap for comprehensive suicide prevention based on the best available evidence. And so we think about what are those individual, family, relationship, community factors that are contributing to stress, contributing to risk for suicide. So we think about broad things like financial security, strengthening economic supports. How are we leveraging job loss, unemployment benefits, housing, changes in loan modifications to keep people in their homes so they're not evicted, because those acute events can be important contributors to risk for suicide. So somebody might not think about partnering with your housing authority in your community, but that's a key partner to have at the table because we know that that attributes to risk. Or job training, educational training, thinking about paid living wages, those types of financial policies that can strengthen people's economic security. But we also look at, creating protective environments. As Matt mentioned, lethal means safety, safe storage practices. There's clearly evidence to support benefit for that. Thinking about, how do we connect people into care before it gets to a suicidal crisis point, expanding access to mental health coverage, mental health care, other types of health care that we know can reduce risk, substance use disorder treatment. I think historically we've siloed mental health and substance use, but we recognize that there is a lot of interrelationship and that we need to be thinking about those risk factors as well. And then really at a fundamental level, from a CDC perspective, we think about upstream prevention in the context of adverse childhood experiences, trauma, whether it's, multi-generational impacts or having trauma-informed care, recognizing that people may not progress in their care if we're not appreciating what they have experienced previously. And I think in the service member population, that is a really important piece given high rates of co-occurring PTSD and other events that have happened along someone's life trajectory. But it also provides an opportunity to get upstream and think about problem-solving skills, conflict resolution. A lot of times we focus that on younger populations as though they're developing those skill sets, but we continue to see in the suicide data that relationship problems, It could be stemming from substance use or mental health or financial insecurity or housing insecurity, but the ability to navigate those challenges also is a way to get upstream in care. So I think for us, it is really looking at that constellation of risk and recognizing that there's not one single solution, that we really have to think about this from a broader community perspective to say, for somebody in a different point in time in their life, these are the things that we need to be focusing on. At a different point, these are the things that we need to be doing. But foundationally, lifting people out of poverty, providing opportunity, connect with jobs, have connectedness in their community, however that's defined for those individuals, play a really important part in reducing risk. And I think we do often want to focus on the acute crisis care and, de-escalating that moment, and that is important, but that's sort of like we're always playing catch up if that's our focus, and there's a real opportunity to get upstream in the work. And I think that whether you're labeling it that way or not, that's what our VSOs are doing, certainly as part of our veteran suicide work and with AWP and many others. You're already doing it. I think it's just an issue of recognizing that that's what you're doing and bringing people together and supporting connectedness and thinking about those other risk factors playing out.
Great, thank you. Dr. Clark, the next question for you is, how does the Department of Defense help transitioning service members and prevent suicide amongst them?
A great question. Very similar to what Dr. Miller was talking about as well, that we have great partnership with the Department of Veterans Affairs. We know that from our data that 12 months prior to separation or retirement from the service is extremely a pivotal moment. It's difficult for the recently separated service member to many times find connection, find purpose, have stable employment. And so in the gentleman that talked prior to us talking about that transition, and I thought it was really impactful of hearing of what is the DoD doing versus what is the VA doing, and how do we make sure we have seamless support? So we're in lockstep with all of the efforts that Dr. Miller has talked about, but specifically we're looking at how do we provide those support services? How do we have any type of warm handover transition for those that might be at heightened risk, and to ensure that we have wraparound services available. One of those is the offering of Military OneSource for recently separated or retired service members and families that provides that 24/7, 365 service support to include non-medical counseling, many of the things that Chris talked about with upstream type of prevention efforts. Military OneSource will then have those. We also have a program called In Transition that for those that are having a medical separation will be warm handover to the Department of Veterans Affairs. And so ensuring that those that might be at heightened risk do have more wraparound services available. But many of the things that Matt had already shared about, we are working weekly on those, as well as the partnership with the Veterans Crisis Line and the Military Crisis Line, of being able to make sure that service members across the world have access to that crisis support, and the partnership with the VA and SAMHSA with 988.
Great, thank you. Next question for you, Jim, is how is AWP applying what you're learning from your research projects?
So we have a great partnership with the CDC. We've been a recipient from their foundation for 4 years, not continuously, but 4 years period. Have developed a really impactful logic model for how communities can reduce veteran suicide by outreach and engagement, finding all the veterans, not just those that are seeking services, but all veterans. Understanding where they are in their journey and where they want to go. Educating them about opportunities, advocating on their behalf. It's what you all do, right? What we all do. Advocating on their behalf and then working with others. And so CDC helped us formulate it, form it, and put it into writing, but also now we're applying it within the Navajo Nation. So we've developed the logic model, and now we're applying it within the Navajo Nation with the goal of reducing suicide, et cetera. I would like to, if I can just interject, there's a couple of things. So one of the things that we saw in our data was the veteran, the service member who was less than 3 years of service. They weren't medically retired, but they were less than 3 years of service. They didn't fulfill a full commitment. They had a huge spike. So I would just say, if DoD The warm handover needs to be those who might have bad paper, or maybe not bad paper, but are being pushed out of the military somewhat quickly. The other thing I wanted to point out, we talked a little bit, Matt, about the Massachusetts. And one of the things that we found, and one of the reasons there's a difference, I think, in our numbers, that what we had, was we found that the counties, and then the states on a larger level, when they aggregate it, undercount veterans' deaths by 25%. Well, when you look at Massachusetts, they undercount it by about 40%. And it's skewed to the younger veterans are not counted, and females aren't counted. But the overcount are mostly older veterans that are dying. Again, I just would say, when we looked at, I think when we look at Massachusetts as an example, their overdose rate might be in that 40% of an undercount, because it's so, that are counted as suicide, they're so high. But the point is that we all have information to share, and we all want to get to the same point at the end. One is too many. We can do better. I love the programs that you all have, DOD has. I think it's a great transition. And I think what the VA is doing with the, where you contact the veterans and you maintain the contact with them.
Solid Start.
Solid Start, thanks. Solid Start program is a great program to do that, because it's a relationship. It establishes a relationship. But what I would say is the nonprofit on the stage, the non-government entity on the stage, is that everyone in the audience that works in the non-government area, we all want to work together, because for our communities and for the communities that are serves communities or combined arms communities, we know the vets. We're eye to eye with them. We're knee to knee with them. We know who they are, and we can connect them to Military OneSource if they don't know it. We can connect them to the VA programs if they don't know it. When I started in Augusta, the Augusta VA director, I said, my goal is to fill your hospital. I want every single veteran in the greater Augusta area to enroll for VHA healthcare. They've earned it. It's free, it's available, and it's in our community. So for us, as a nonprofit community, we want to partner. We want to work together. We have a great relationship with the CDC and DOD and VA. We look forward to working together too. Thanks.
Thank you, Jim. Back to you, Dr. Clark. Can you talk about the other broader suicide prevention programs that the DOD implements?
Sure. And Chris, thank you so much for talking about the CDC's technical package and that public health approach. And similar to Dr. Miller as well, the DOD also institutes a public health approach, and the backbone of those efforts and really looking at our program is based on the CDC's technical package and the 7 elements. But when we're looking at the data, what you're hearing on the stage today is, yes, the data is there, but what are you doing about it? And so our focus is really in 3 different areas, but all within this public health approach to suicide prevention, but looking at that more primary prevention, upstream prevention efforts. But specifically, we're looking at fostering a supportive environment and increasing quality of life. One of the things that Secretary Austin is dedicated to is a primary prevention workforce that is down at each of the installations, and that's pulling in your suicide prevention folks, your domestic violence, your sexual assault, sexual harassment, but truly that integrated primary prevention down at the unit and installation level. We're also doing on-site installation evaluations. So then with that primary prevention, what are the installations doing? What are their efforts? What are the policies that we have? And are they being implemented down at the installation level? And we've gained significant knowledge of what's actually happening from the department level down to the headquarters to each of the installations. We're also, with our year-long campaign, it's Connect to Protect, support is within reach. Very similar to what we've talked about today is ensuring that we are connecting those resources. We are providing that support system for service members and their families. Lethal Means is a significant effort within the department, echoing many of the things that Dr. Miller has also talked about in partnership with the VA, with the White House and HHS about lethal means safety and developing a campaign plan. We've also developed toolkits down for service leaders as well as firearm retailers outside of the military installations. So really promoting that culture of safety. So not just talking about suicide prevention efforts, but truly instituting a culture of safety around safe storage. We've been very successful being able to provide that. We're also looking at increasing training, so those that are selling firearms will have access to what does suicide risk look like? How do we ensure that we're promoting that, that safe storage of firearms? The other thing we're doing within the department is we have the Suicide Prevention and Response Independent Review Committee that stood up this past May. It is an independent committee, and they're out visiting 9 installations to include OCONUS installations in Korea and Alaska. We're expecting that report to come back in February, but we're really excited to be able to see what is truly happening at the installation and focusing not just on your suicide prevention efforts, but what is happening down at the installation. What is their quality of life efforts? What resources and support do they have? What does their housing look like? And so we're really excited to be able to see what comes back from that will significantly enhance what our efforts are going to be. But just echoing what Chris had talked about with the data is we know that so many of the those that have died by suicide have a lot of things going on in their life. They have relationship issues, many times financial issues. And so we're making sure that we are trying to look at this through an integrated primary prevention and public health approach that truly involves those that are just outside your suicide prevention with financial readiness, with supportive environments, with making sure that they have access to mental health care, with appointments. And so those are some of the high-level efforts that we're doing.
Thank you. Thank you, Dr. Clark. Dr. Miller, the next question for you is, what is the VA? Can you describe some of the VA's research efforts in the field of suicide prevention?
Sure. I guess I'll approach this maybe with a real quick story. I think I saw Jim. Isn't Rep Rowe, Dr. Rowe, isn't he on your?
He is.
Yeah.
But I don't know if he's in the room.
So
Yes, he's in the building.
the first year in the building.
Elvis is in the
Elvis, yeah. Thank you very much. The first year that I was the director of the Veterans Crisis Line in 2017, we hosted Representative Rowe at the Canandaigua Center. And he taught me something really important in that. I was a little nervous, it was my first site visit with a congressional rep, a chair of the HVAC. And we're going through the tour. I think it's just going wonderfully well. And we get out of the elevator on the second floor of the call center, and he pulls me aside. There's me, Rep Rowe, and a big fake plant. I remember that. And he leans in and he says, is it working? And I said, excuse me? He said, how do you know it's working? How do you know it's making a difference, the VCL? And so I started talking about all these numbers and all these metrics, and he came back to me and he said, but the suicide rate is still going up with veterans, right? I said, yes, it is. And that was an important, I think, experience for me in terms of understanding that in research, it can't all just be about that outcome of the rate in the end. Yet collectively across time, you got to see that rate going down for the investment that's being made and the efforts that are being made. And it's going to take that collective approach that Chris mentioned, because there isn't one answer. There's not one answer or solution for one person, let alone for the population as a whole. So my point then for us in this setting is this. We've talked a lot in here about the advances that we've made in the public health approach over the last few years with suicide prevention and the collaboration that's created with the community. We've developed in the VA over 600 community coalitions. We're in 49 out of 50 states and 5 U.S. territories with the Governor's Challenge. The next step is applying rigorous program evaluation and research to the work that we're doing together to build a body of literature towards better understanding what works, for whom, when, and what gets the investment of limited resources. So I think our next step, and what we're really working on together with you and with ourselves, honestly, is tightening the program evaluation and converting that program evaluation into rigorous peer-reviewed research.
That's exciting. Thank you, Dr. Miller. We just have about 5 minutes left, so I'd really like to take an opportunity to, one, thank the panelists and also offer you the opportunity to offer any closing words or closing remarks. So we can start with you, Jim.
Yeah. One of the things I'd say, Matt, in terms of, I agree, you need to have rigorous program evaluation. Here's the guy. They did this, the foundation and the CDC led an effort to help many community-based organizations measure their impact, develop their program with measurable outcomes and that were impactful. And you have all of the literature, the CDC does. I think, you know, they're great partner for you, great partner of yours. I think that when I think of public health, I think of the CDC. And I think that what's already been developed is there. I want to thank Ramya for hosting, for moderating this panel. I want to thank the government for being here and DoD, CDC, and the VA. We all want to work together, and we just have to figure out a way that we can do that. And I thank everybody for being here.
I feel like Jim is auditioning to come work as a CDC spokesperson. You're hired. No, but I was going to say something similar in that, one, it's a real honor for us at CDC to be a part of this because, you know, natural places would be DoD and VA. And I think we have really embraced our work with VSOs in particular, but also with our partners who are serving veterans and service members and trying to reduce suicide among that population. And I'll just say you've heard some really good things about our work with CDC Foundation and VSOs under our veteran suicide prevention evaluation work. There is a current opportunity for VSOs to apply for being a part of the next cohort and funding that's been extended through October 11th. So if this has sparked your interest, I think it is something where we have learned a great deal from what, you know, really grassroots community level efforts from VSOs, connecting with the community, connecting with veterans and others, are able to move the needle. And we have leveraged that in our broader comprehensive suicide prevention work. Veterans are a focused population of our funding that goes to state jurisdictions or universities. We currently fund 15 states and 2 universities as part of that work. And we've found that it is really helping folks think through, we're all well-intentioned, we want to do the right thing, but are we doing the right thing? Is it working? What could we be doing differently to make even greater impact? And that's really the focus of that partnership through that evaluation work, is to put it on paper, to really think through, this was a good idea, but it's not really feasible, or it's not doing what we wanted it to do. And I think too often we sort of say, this feels right, so it must be right. But there is an opportunity to bring rigor, to really understand we are making an impact, and then to document it and scale it and share it with others. And I think that's a key part of that work, and certainly happy to continue that partnership with many of you, and certainly provide whatever resources we can to our DoD and VA partners as well to have that shared learning so that we can move the field forward together. So really appreciate the opportunity to be here.
And I'm honored to be here. Thank you so much for the invite. And as Chris has said, we cannot do this alone. And so this partnership with the non-governmental organizations is vital to our efforts and truly to have an all-of-nation approach where we can save lives. And so we're just so honored to be here. Thank you, for the opportunity. And we're really excited, Chris, for your program evaluation as well, because in the Department of Defense, we're also taking a hard look at that of each effort that we're doing. Why are we doing? Is it producing the results that it was intended to produce? And then are we going to continue to do this effort? And is it actually saving lives? So thank you for that framework. We absolutely use that. And to just piggyback on what Chris said too, that if there's, folks here that have efforts that we can connect with within the Department of Defense, please reach out to us because we are that focal point of being able to work and connect to the services as well as with our efforts at the policy at the departmental level. So thank you so much. And Ramya, thank you for moderating this.
I read a article back in 2019 that really stuck with me. It was an article on, the title was along the lines, basically my translation, what are we missing in suicide prevention in America? And it was written by Eric Kane, someone I think, Jim, you worked with for a little while, at least with Operation Deep Dive. Brilliant researcher and thinker in suicide prevention. And, one of his main points in what are we missing was we're not missing brain power, we're not missing motivation, we're not missing the will for something different. What we're missing is collective engagement. And what's going to be required is for all of us to get on the same page, get on the same plan, and work together in coordinated yet also unique ways to make a difference with suicide prevention. VA can't be all things to all people and isn't going to try because it's not going to happen or be effective. And that's where partnership is so important. So really, really thankful for that and thankful to all of you.
Well, thank you all. That wraps up the panel.
Yeah.
I
see.
don't believe there's a microphone, so is there a...
Be loud enough.
Okay.
I'm Tina B., Marine Corps veteran. I work in a nonprofit for veterans. And actually, Dr. Miller, I appreciate that the VA gives out locks for gun safety. So if anybody doesn't know that, that's a great thing. I really appreciate that. One of the issues that we've had with our veterans is that when they're meeting with their mental health provider, sometimes they call or they send a message and that mental health provider is out. No one is answering those. My mental health provider was out for 2 weeks and no one answered her messages, her phone messages, her secure messages on My Healthy Vet, and that's a real problem. Do you have a way that you guys are going to start looking into that? And, you have PTSD and I need somebody to call me back. My veterans need somebody to call me back.
Absolutely.
We really need something to happen with that. Do you guys have a way to start looking at that?
Hey,
So-
could I ask you to repeat it?
Oh, yeah,
Summarize
sure.
it, repeat it so everybody can, no, it's okay. I just want to make sure that those who are virtual get the full bit of it.
So, Maureen, I apologize. I'm going to try to repeat this, but it will not be verbatim. The essence of the question is, veterans need to get in touch with the VA, and there are mechanisms to do that, but it's not working in some particular cases, and that may generalize to other cases, and that's concerning. So what are we doing to work on better contact with veterans who are in VHA care, specifically in mental health? Did that cover it, Maureen?
Yes, sir.
Okay. So this goes back a little bit. It goes back to around 2014, 15, when we discovered, actually it was through a suicide, we discovered that we have a ton of numbers out there, and a lot of those numbers aren't connected to then the system as a whole. So they could be connected to a VA provider's desk phone. And if that VA provider is on leave for 2 weeks, that message isn't going to be retrieved for 2 weeks. So what we started doing back then is pulling back that process where providers have separate voicemails and it may go unchecked for long periods of time. And what was supposed to happen is every VA facility is supposed to have one primary forward-facing number. And that primary forward-facing number is supposed to connect them to a live person. I don't know why I said live. It's supposed to connect them to a person 24/7. So if that's not happening, that's something that we need to know about, and that needs to be worked up. Second, what I'll say practically in the meantime, on this forward-facing number, you should be offered an option. It's called Press 7. If you press 7 on this forward-facing number, guess what you get a direct connect to right then, right there? The VCL. The VCL specifically within 988. So then that's an opportunity for someone to say, I'm struggling, I'm having a hard time getting to my provider. Can we talk, and what can we do to work this? We're there, we'll address it, we'll take care of you.
Thank you. Thank you again, Dr. Miller. You can always, there is contact information for the panelists if you want to reach them after this event. And thank you all for coming.
Thanks, Rami. Yeah, we'll